Hi, this is Mark Newman, president and founder of Precision Analytical, and I'm excited to bring you this video today that is one that is many years actually in the making in terms of the data. This is a topic that's been something I've been digging into for a long time, and that is just the mysterious results that we get in the lab when people are on transdermal hormone creams and gels. So we are going to unpack that a little bit for you today and help you as you are monitoring people's therapy that happen to be on those products. Transdermal hormones have historically been this sort of mysterious creature of trying to figure out why, if I put a hormone on my skin by a cream or a gel, that I'm getting these astronomical saliva values, and the serum and the urine tend to lag behind. And for some people, they've just thrown their hands up. But there's actually enough data now that we can make some sense out of this. And that has really clarified recently for me with some of the data that we've pulled from the thousands of patients that have done urine testing with us, along with some of the clinical data that's been done over the years. So this is what I'm going to attempt to prove to you, is that my current position on this issue is that transdermal estrogens are best monitored with serum testing or urine testing, like our Dutch test, our dried urine test for comprehensive hormones. And that transdermal progesterone behaves differently and is probably best, if used, monitored really with clinical symptoms, and the labs are not a lot of help when it comes to transdermal progesterone. So here are the assumptions that I made over the years at different times that really prevented me, I think, from understanding this correctly. And one is that conceptually for HRT, that we need to get people back, particularly as we're talking about estrogen, into the premenopausal range, that they need to be in a healthy premenopausal range, maybe where an average premenopausal woman would be, in order to have the kind of response that we want clinically. And we're going to talk a little bit about that and what the data says about that. Serum and urine estrogen levels do not go up with creams and gels. You do see this really more with progesterone, but with the estrogen, the levels really do go up, and it is in a linear dose-dependent manner, and this is really important in terms of using them to monitor therapy. Saliva, the saliva gland, is a tissue, and the saliva that comes from it speaks for that tissue, but there has been this assumption, that was a reasonable assumption until it's been further explored, which it now has, that the saliva gland really speaks well as a surrogate for all tissue: breast tissue, uterus, brain, bone, all of these different systems in the body, that if we look at what happens in saliva, we know what happens there. And it really doesn't for this particular scenario of monitoring transdermal hormones. And then lastly, a lot of the understanding that we get from transdermal hormones comes by way of progesterone creams, and then we often extrapolate that to how estrogen responds and behaves, and they really have some key differences that makes estrogen a lot easier to monitor than progesterone when you're talking about transdermal products. So here's where we're going to start with this. We're going to start with estrogen patches because it's an easier to understand system. There's a lot of data. And then when we move from patches to gels and creams, we're going to see some things that I think will really help clarify what's going on in these situations. So here's where I've got a collection of data. Most of this is from the FDA studies that were done on these products, because these are pharmaceutical products, right? So they've gone through pretty rigorous testing, and they've looked at what happens to serum estradiol levels when you increase the dose of a patch. So you can see the patch dose here, not on therapy, and then you can see the lowest dose of the patch here, and then on up we go and into a premenopausal range. Then when we look at the transdermal gels, you can see slightly lower numbers. Notice that even the values without therapy are lower. And the reason for that is these are different studies, right? So they're using different methods. They're getting slightly different results. So if you account for that little shift, that methodological shift, there's actually really similar differences or similar results when we compare the commonly used doses of pharmaceutical products that happen to be estradiol gels like Divigel, and when people use patches. So you get a similar response in the serum. So with estrogen patches, estradiol patches, serum and urine, I'll show you the urine data here in a second, move from low, meaning the postmenopausal range, up to within the premenopausal range as the doses scale from 0 up to 0.1. Bone loss, and this is really key. This is important data. Bone loss and vasomotor symptoms or hot flashes improved at all doses. Okay. FSH is suppressed. I got this from a couple different studies where they looked at what happened to FSH when you use different doses of patches. There wasn't as much data on that in terms of all doses, but when you look at moderate doses of patches like 0.05, FSH is suppressed if you look at the studies and average it out about 40%. So it goes from a postmenopausal FSH down to below that range, not into the range where you'd find a premenopausal woman, but you do get the FSH suppression you'd expect to see at about 40% when you use a patch, okay? Now, when we look at urine testing, you can see similar results here in that the patches start women off here in the postmenopausal range, and then they climb just outside the postmenopausal range with either the low dose of the patch or the low dose of the creams or gels. So you're climbing just out of that postmenopausal range, and then you head up into the premenopausal range with these products. Those are our results from over 1,000 women and our reference ranges. So you can see a very similar trend for both patches and the creams and gels when you scale up through the most commonly used dosages and you're looking at urine results. So that's a nice intuitive relationship that we see there. Now, with the creams and gels, again, serum and urine move from a postmenopausal low up into the premenopausal normal range as you scale the dosing. Bone loss and hot flashes, and this is really, I think, important in terms of the parallel with patches, improved at moderate and high doses. However, the bone loss at the lower doses did not improve quite as much. The FSH suppression was very similar. So the FSH suppression you find in about a milligram of an estradiol gel or cream is pretty similar to what you get in the patches. But I want to hone in on this point here because this is it was a critical data point for me. When they look at hot flashes with estradiol gels, and you look at 4 weeks, there was no difference compared to the placebo group, although at 5 weeks there was a difference. Similarly, with bone loss, you didn't see an improvement in the bone mineral density at 6 months, but you did at 12 months. So at 6 months, you saw that improvement with the higher doses, and you saw that with all patches. With the hot flashes, similarly, at the early time point of 4 weeks, you saw a difference with the placebo group in the higher doses or any dose of patch. So what does that tell you? It tells you that 0.25 milligrams of a transdermal estradiol is just enough to start challenging the low doses of the patch. So it is a fairly low dose of estrogen in terms of what happens with FSH suppression, in terms of what happens with bone loss and hot flashes. Now, why is that important? Because when we look at saliva testing, and this is what's made this scenario so really complex to try to work through, is saliva testing implies that 0.25 milligrams is actually a relatively high dose. So when we look at the highest dose of a patch here and a higher dose of the transdermal creams or gels, there's a 20-fold difference there between the salivary values of what happens with the cream and what happens with the patch. And when you look at this lower dose of 0.25, you can see that is up and above the premenopausal range, meaning when I scale up using saliva testing with a patch, I go from the postmenopausal range to within the premenopausal range. That's very similar to what you see in serum or urine. But when you start using transdermal products that are gels or creams, you get this exaggerated response, right? So it implies that that dose of 0.25 and 0.5 are really quite large doses of estradiol, but the clinical picture of bone loss, hot flashes, FSH suppression does not jive with that message. And so what that leads us to do, if this is our monitoring tool, is to use doses that are significantly lower at, say, 0.05 or 0.1. And when you do that, usually the saliva will hop up into the premenopausal range, maybe even a little bit higher, and then you have a lot of confidence that you have enough estrogen. But when we look at the clinical data, it really implies that serum and urine, as they're responding to those same doses, are telling a story that is in more alignment with the clinical picture. So what do we learn from saliva testing? We do learn some things. I don't think the data supports it as a monitoring tool to monitor transdermal products, right? Those elevated values don't seem to parallel what's going on at the tissue level. There's an exaggerated response in the saliva gland for some reason, but we can learn that some tissue get more than what you see in the serum or the urine, meaning serum and urine do not reflect the saliva gland very well. It gets more hormone than what you see there. You'll also learn, if you look at some of the data that I've acquired that I didn't include in this lecture, the tissue closer to the application site get more hormone, which makes sense. But if you put hormone on your cheeks, if you put hormone around your neck, you will get a lot in your saliva. Your salivary response will be super high. Whereas if you put it on your forearms or your belly or your thighs, you're going to get dramatically less. There's a study that Dr. Chang did where he put progesterone directly on the breast and then measured breast biopsy samples, and the samples increased like 100-fold in progesterone because there's direct diffusion of the progesterone into that tissue. If you put the progesterone then on the thigh, obviously you're going to get more in that region, but the breast tissue are probably not well reflected by the saliva, the salivary values in that situation. Now, what does that mean? Well, if you're talking about estrogen, then we probably should, due to that, and this is very intuitive, is not put the estrogen very near estrogen-sensitive tissue if we're concerned about things like, for example, breast cancer. That putting estrogen near that tissue might be something we want to avoid because there's a relationship between where you put the hormone and how much hormone there might be in a particular tissue. So, having said all of this, how do we go about dosing transdermal estrogen? We want to do it safely. We want to do it effectively. Generally, lower doses are considered safer when we're thinking about things like breast cancer, but then are they effective in terms of relieving hot flashes, in terms of helping those bones to be stronger? Also, in terms of safety, nice thing about the urine test is we can add in the estrogen metabolites, which helps us with our safety profile. But in terms of a general approach, the dosing that leaves the values here, meaning I've climbed out of the postmenopausal range, gives you a similar clinical impact as higher doses, higher levels, but it's a little bit delayed. So if we're being conservative, we're going to get some bone help at those levels. We're going to get some help from hot flashes at those levels, but you would be more assured of having the protection from, say, the bone loss at these higher levels up into the premenopausal range. But then we need to balance that impact, which is positive, with our concerns that we may have in terms of someone's relative risk for getting breast cancer. And that might be different patient to patient. If someone has a sister who has breast cancer, I might be less aggressive with her. If I have someone who's got a history of osteoporosis and I'm really worried about her breaking a hip in a few years, then maybe I'm going to approach that differently. But what we know is that this data can be very useful in terms of tracking that. If you put a woman on estrogen and she finds herself within this postmenopausal range, she's probably not getting enough to help with things like bone mineral density. As you get out of the postmenopausal range, you're getting some of those effects. And as you scale higher than the early part of the premenopausal range, there may not be a significant improvement in terms of any of the clinical impact. So we may want to think about that when we're dosing and monitoring patients, that what is the value of pushing people way up into the premenopausal range that may not be the approach that we want to take. And again, it does depend on the particular scenario. So generally, advice I think that is wise is to start low and go slow. Give it some time. What do I mean by that? Well, at 2 weeks in this study, we're talking about vasomotor symptoms. At the lower dose, you can see that it's barely separated from, this is the placebo group up here, right? but look at 12 weeks. At 12 weeks, you notice something pretty interesting. This is a patch. The lower dose patch got outdone by the higher dose patch at 2 weeks and 4 weeks. But as you got into it, 10, 12 weeks, there's not a lot of difference there. Now, this may be different than what's happening with bone mineral density, but it is interesting that it took a good 10, 12 weeks for that lower dose to really have a maximum impact and to be completely separated from the placebo group. Okay, so and don't forget the placebo. If you give someone a dose of 0.05, right, and this I think has confused this whole question, is if I give someone a dose that truly is a placebo, their hot flashes will get better generally, right? You can see here, half of the impact here that's going on for relieving hot flashes is from the placebo effect. So if you're giving 0.05 as a dose, monitoring with saliva testing, and it's up into the premenopausal range, but you are not monitoring their bone mineral density, there might be something that we're missing. Okay, and then of course, in most situations, we're going to want to balance with progesterone. Now, that brings us to this question of, okay, if this is true of transdermal estrogen, then is it also true of transdermal progesterone? And my position would be that the dose of transdermal progesterone that's appropriate is not something that you can really figure out with lab testing. That none of the lab tests are really very effective for monitoring progesterone. That would be a longer conversation to go into in detail. But if you want to look at the urine dosing and values, let me show you this. Okay, transdermal progesterone. So here's a postmenopausal woman who's not on transdermal progesterone. They're in the middle of the postmenopausal range, far separated from the premenopausal range, right? So when you give them even 20 milligrams, it does go up a little bit. And when you give them 100 milligrams, it goes up a little bit more. But you can see that to push a woman up into the premenopausal range takes pretty outrageous doses when you're using urine testing. So as the values scale up, there isn't a linear dose-dependent response, probably because progesterone's more lipophilic. It's more fat soluble, so it's going to diffuse into the fat tissue, and the manner in which it's getting into tissue, including the saliva gland, is still a little bit mysterious, but this does not encourage us to use urine testing for monitoring transdermal progesterone, particularly in postmenopausal women. Now, this is the second progesterone metabolite. So this is the alpha metabolite, and you can see it goes up a little bit higher. So at 200 milligrams, it's getting pretty close to the premenopausal range, but that's a lot of progesterone. And at 20 milligrams, it's gotten them out of the postmenopausal range. So if you wanted to use this, maybe getting up and out of the postmenopausal range would be a good goal, but it's still not an ideal monitoring tool. And as we go and look at these scenarios of these types of doses in saliva, there is just an astronomical amount of progesterone in the saliva for those doses. It's going to be really variable as you monitor it one day versus another, but it does show you that there's a lot of progesterone going into the saliva gland at those doses. So when we're looking at transdermal progesterone, there is still this somewhat mysterious dichotomy that we see between the testing types and what's going on in the uterus, in the breast tissue, may be somewhat of an unknowable in between in terms of the messages you're getting from the different testing types. So I think you want to be careful with that. I think you also want to be careful anytime you're giving transdermal progesterone when there's estrogen on board. But with the estrogen itself, the testing in urine and in serum is really responsive to the dosing that you're giving and can be used effectively. So again, my false assumptions to start with, you've got to get back to premenopausal levels. I think that's in some cases a little bit more aggressive than you need to be. Serum and urine testing doesn't go up with creams and gels. It does. We've shown that data that it does have a linear dose-dependent response. And we've also seen that saliva testing, the response you see there does not speak well for what's going on with the bone and the brain. Estrogen and progesterone behave the same way. They really don't. And so we've got to separate them when we're trying to figure out what best practices are for different situations. So you want, I think, at least to be out of the postmenopausal range if you're wanting to see that impact on things like bone. Serum and urine levels parallel the clinical effects very well from what we've seen, although we have not seen breast biopsy tissues and uterus biopsy tissues at these different dosages. So there really are still some research questions to be answered. Saliva testing really doesn't help in terms of monitoring dosages, and transdermal progesterone again, may not be the best option when estrogen HRT is on board, because at those doses that are effective, you're getting systemic uptake of estrogen, and progesterone at that sort of analogous dosing, there still is a little bit of an unknown in terms of where that progesterone really is getting to. So that's something we need to continue to think through. So why would we do Dutch testing on these patients instead of just serum testing? So serum testing is an option. All-day average, I think, as you look at these 4 urine samples that represent most of the day, is probably better than one point in time, because those levels are going to go up and down some. With a patch, they're going to be a little steadier in serum, but with the gels and creams, you're going to get an up and down kinetic pattern throughout the day, and the urine's going to average that out a bit better. Metabolites are really key, particularly if you know you're getting systemic estrogen absorption, is making sure that the estrogen is being broken down in terms of the 2-hydroxy, 4-hydroxy, 16-hydroxy estrogens, as well as methylation. And then, of course, we're going to expand that further, looking at cortisol, androgens, and the organic acids and other markers that we've got on the test. So if we're looking at, for example, estrogen metabolites, this would be an example of a woman where we can see that her parent estrogens are high. If she's on estrogen therapy, that's a lot of estrogen. But the thing we can add into the picture with the Dutch test is you can also see, look at her 2-hydroxy estrogens. Her 2-hydroxy estrogens are really pretty low. They're below the premenopausal range, meaning this pathway, this 2-hydroxylation, is not going very well. So that's a woman who might need some diindolylmethane, some DIM or I3C to really push these estrogens better down their phase 1 detox pathway, but she may also be getting a little bit overdosed. So that's something we can see there. If we're giving her a little bit of transdermal testosterone, or if she just has high testosterone symptoms, of course, you can see here this woman's testosterone is not high, but again, the power of the metabolites, we can see that there is some 5-alpha preference going on here. So if she's got facial hair, things like that, we can see really that she's got a metabolic preference towards high androgen symptoms, and that's again something we can see with the androgen metabolites. For cortisol, again, just more information that we can see on these patients. Having a cortisol that's really out of whack is not going to be helpful at all for a patient that you're trying to control in terms of hot flashes. So a woman like this is from a Dutch Plus, where we're looking at the salivary cortisol. The difference, the cortisol awakening response, is the difference between those 2 points. And when that's exaggerated, which is quite large, even though those are all within the normal range there, that's a pretty exaggerated cortisol awakening response, and that is not going to help us in terms of controlling hot flashes if you've got the HPA axis in overdrive. So there may be some lifestyle things we need to look at, or maybe some ways to kind of calm down that HPA axis, but adding that into the overall picture when you're looking at an HRT case can be very helpful. And then, of course, we've just added the Dutch extras, which can be helpful as well, where we can see some additional things. For this particular patient, we can see the methylmalinate's high, so she may have a B12 deficiency. The xanthurinate's high, so she may have a B6 deficiency. And then you can also see on this particular person that the serotonin metabolite is low. So if she's depressed, right, that could be related to her overall picture in terms of her hormones, but there could also be a neuro angle to that as well that we might want to look at. With the recent addition of the OATS, we're really starting to see some exciting data looking at the synergy of the hormones with the organic acids. This classic example being that when tryptophan can head down these different pathways, the kynurenine pathway or the serotonin pathway, that cortisol and estrogen actually help push it down this pathway towards NAD. Right? What does that do? Well, if that is excessive, then you're going to have less serotonin available, and you might end up with a low 5-hydroxy indoleacetic acid. Now, that's going to be more of a picture of your overall serotonin, but if that is getting shunted down that other pathway, then there could likely be a deficiency in terms of what's going on in the brain. And if you see a low result there and the patient's depressed, then that's something to think about in terms of addressing. But as we go further with the patient that we just saw, if there's also a B6 deficiency, so this pathway here is B6 dependent right there. So if you have a deficiency, then you're going to get high xanthuric acid or xanthuronate like we saw on this particular patient, and that's going to cause problems because it complexes with insulin. So you're going to have less insulin sensitivity because of your B6 deficiency. So we start to put this larger picture together that, yes, you can use a serum test and just get an estradiol value, or you can expand it with the Dutch test and look at metabolites and some of those markers. But as you expand into the realm of the Dutch Complete and the Dutch Plus, now we're giving you more information to really start to see how some of these things come together and can impact the patient's health in ways that are really addressable. If a patient that has high xanthuronate, potentially because of that estrogen or potentially because of that high cortisol, and you give them vitamin B6, then it's going to open that pathway back up to NAD, and your xanthuric acid will go down, which may also positively impact your insulin sensitivity situation for that patient. So a lot of exciting data that we can look at. If you have any questions on the data that we're looking at here as it relates to transdermal hormones, feel free to reach out to us. You can send questions to info@dutchtest.com, and we thank you for listening.